subluxation
Dislocation.
risk would be kind of the main consideration there. So what side of the bed would we be rolling them towards? The left, very good. We would roll them onto their left side. I would maybe, as the therapist, provide some contact into their right hand and try and get them to push through that hand to help them come up to stand, because they should be able to use their left side on their own in order to be able to do that. So those are kind of the main things we're considering as far as the bed mobility goes, as well as the transfer. Now, what about if this was my total hip patient? Would that change same side is affected? It is a right total hip replacement. Does that change anything about the transfer?
You would guard the
We
strong
would
side.
guard so the left side is unaffected, right side is where the hip replacement was. What side are we going to transfer them towards? We're still transferring towards the left.
So we guard the left. Guard the left.
Okay, someone who said guarding the left. Why are we guarding the left for this patient?
And they can't catch them.
Their good leg could give out?
Because they're putting more pressure on
Full weight bearing.
So they are full weight bearing on their left. What weight bearing are they on their right?
Non-weight bearing.
So what did we talk about with hip and knee replacements as far as weight bearing status after surgery?
As tolerated.
Weight bearing as tolerated is 90% of the time going to be what you see, unless there's something happened with surgery that was unforeseen, or like usually if they're doing a hip replacement or a knee replacement, they have to be a certain minimum level of health. So if they had like severe osteoporosis or something like that, they're probably not even going to do the surgery. They're going to try and do something to correct that beforehand. So they should be weight bearing as tolerated. So you still want to guard the affected side. Unless you got them up to stand and they're like, this hurts so much, I can't bear any weight, and they become basically non-weight bearing, then you would guard the strong side. But generally they should be attempting to bear weight through that leg. And if it was painful, they would potentially give on that side. So you want to guard the affected side on a total hip. What about a total knee?
The other side.
Why?
Incision. They don't want to.
Anterior knee wound. Very good. So if there's an anterior knee wound, we're going to guard the strong side. And then what about your like ACL where they're non-weight bearing on their right side?
Guard the unaffected side.
Then you would guard the unaffected because they're non-weight bearing. So any non-weight bearing or anterior knee wound are the reasons why you would guard the affected side. What about bed mobility for your knee and your hip patients? What does that look like? Do we remember?
TKR, the affected knee is extended.
The knees, what are you doing as the therapist? You're just guiding the leg, right? So what side are they going to get out of bed towards?
What side is affected?
The affected side.
All right, one confident person give me the answer. I heard a lot of talking.
The non-affected.
So you'll guide their affected side as they're bringing their leg down. You'll go, I guess you'll start off on the good side and then slowly bring the leg down so you don't just.
So what side are you standing on? The right side's affected. It was a knee or a hip.
I'm standing on the affected side.
So you're standing on the right side. What side is the patient getting out of bed towards?
I guess. This unaffected side? No.
So if you're standing
That
on
makes
the
sense.
right side of the bed, you want to reach across.
Yeah, no, that doesn't make sense.
No, that doesn't make sense. So you're going to get them out of bed to the affected side, but you will still transfer them towards the strong side. So getting out of bed and transferring can be two different directions. So if they have, some reason, like their arm strength should be good, they should be able to come up to like, what is it called? Like the like they're supported on their arms. You're just helping them guide the leg. So you want to do that towards you. And then you'll transfer them towards the unaffected side. Make sense? So again, the standing, dependent, pivot, there's a lot more wrinkles based on what the diagnosis is. But I think having the opportunity to talk about this will set us up for some good practice later. Anything else with the standing, dependent? Just for talking points, I think that. Okay, so mild generalized weakness in all 4 extremities. What are our considerations? What are we thinking about doing? Yeah, so what amount of assistance are you thinking you're giving this patient?
Minimum assistance.
Minimum to moderate, typically. It could be max, but if it was max assist, it'd be more like mod max. And what are you doing with this patient that you're not doing with your severe generalized weakness patient?
You're allowing them to produce the movement a little bit themselves.
Yeah, you want to cue them. So I want you to be pushing here to roll to your side. I want you to be pushing here to come up to stand. They may or may not be able to do it fully by themselves. That's why you're there filling in the gap. So, if they're more like a 3+, even like their arms might be a 4- and their legs might be a little weaker. So you're cueing them to do as much as they can do and you're assisting less. Whereas what's going on with your severe generalized weakness patient? You're pretty much doing all the work for them. If they can move their stuff a little bit, you're going to cue them to do it, but generally you're placing everything, doing everything for them. Make sense? Yeah. Typically, there won't be a more affected side. There might be, but for the cases for this course, they'll most likely be pretty equal left to right. So whatever side you're transferring towards, getting out of bed towards, doesn't matter. So it's all about body mechanics and making sure you're cueing them correctly if they're able to do stuff on their own. T9 spinal cord, normal strength in upper extremities, no movement, lower extremities. What are we thinking about? So slide board, or what would your other option be more likely if they had already done the slide board? Lateral swing, very good. And then what did you say? What was the other word you said?
I don't know.
It was the first word you said.
I don't know.
Coaching. So
Okay.
coaching, teaching. This is, are you still using the head to hips ratio?
No, because they have upper extremity strength.
Yes, you are. They have the upper extremity strength, but they are generating the head to hips ratio themselves. So this should be, again, more like min assist, maybe mod. Again, it could be leaning towards max, but you're still teaching them. You want them to initiate it themselves. So you aren't resting their head on your shoulder. That's for your max assist patient that you need to do all the head to hips ratio and movement for. This one, you're teaching them to do it themselves. So you're here, you're bringing your head to the left, to scoot to the right. They might have to do that multiple times. They might lose their balance on the way, so you're still pretty close to their knees. You're not blocking, but you are guarding. But if you're not, this is the one where if you're not teaching the patient, if you do a dependent transfer with a slide board, you're gonna lose points for not having your patient do as much as they can. So this is more teaching, facilitation, with filling in the gaps that they're not able to do, whereas your dependent, your severe general weakness patient, it's still head to hips, but Their head is on the opposite shoulder of the direction you're going. You're having them wrap their arms, you're getting in nice and tight, and then you need a big weight shift just to unweight their bottom and turn. And then below knee amputation, we kind of talked about this already. What are you doing? Guarding the strong leg because they're non-weight bearing on their affected side. What about if they did have their prosthesis? Then you would guard the affected side. Same thing, they should have good arm strength, so you're cueing them to do as much as they can. Height of the bed in relationship to the wheelchair. Thoughts?
Depends which way you're going.
Depends which way you're going, and it also depends on the type of transfer, right? So if you are doing a slide board transfer from the bed to the wheelchair, what's the height relationship?
Bed's slightly higher.
The bed is slightly higher than the chair. If you're doing it from the chair to the bed,
Bed
Bed
is
should be
lower.
lower.
bed should be lower. Usually when we're lowering it all the way, it's about the same height, but as the weight goes into the mattress, it will start to go down. It should only be slight. It shouldn't be a big difference. They're not going down a slide. You just don't want them working uphill against gravity. What about standing transfers?
Wheelchair should be higher.
So the bed will probably always be a little bit higher. Is there a particular patient that you might leave the bed particularly higher for?
Knee replacement. Or a hip.
Someone, I think the first person I heard said it.
Hip replacement.
Yeah, why the hip replacement?
Because they can't flex their hip.
Because you don't want them to flex the hip beyond 90. So coming up to stand, sitting back down, regardless of what direction you're going, they're less likely to break the precautions by having the bed a little bit higher. You can't change the height of the wheelchair, so you gotta cue them when they're coming forward, scoot the butt forward. When they're coming up to stand, kind of keep the chest tall, relatively try and lead with the hips. Same thing coming back down. Once the transfer is complete, when is it appropriate to let go of the patient?
They're secured and like completely seated where the positions they need to be, and then put on the bed rails.
The guards.
Well, I mean, after.
So if you're transferring to the wheelchair, what needs to happen?
Brakes.
Brakes are on. I mean, the brakes should already be on, but you might move them a little bit first.
One of the handbars.
Handrails need to be in place. Ideally, like if it's the dependent patient, definitely put the footrests up. And if it's not a fully dependent patient, they might be able to have the feet down, and that would be fine. The leg might need to be kind of extended for your knee and your hip. And then in the bed, when can you let go of the patient? Yeah, once they are lying down. When they're sitting up, you should still have your hands on them. You can take the belt off while they're seated if you want, but your hand stays in contact with them, and then lay them down, and then you can take your hands off, but you can't walk away until the bed rails are up. We're sticking with 3 rails up. Whatever I was told week 1 by one of the other OT professors, that was a rule specifically to their hospital, as far as I can tell. Nursing homes are more so getting away from leaving bed rails up, and again, you need the orders to keep up too. But as far as we can tell, there hasn't been any official change in like the state as a whole or anything, as I was told. So it's going to be different depending on where you go, but for us, we are still teaching 3 rails up. The leg rail will be down on which side? The strong side, the unaffected side. Try and get out of the use of saying good and bad. Even strong makes you prone to saying weak. So affected, unaffected is your go-to, or just left and right. But when we're talking about cases, we would need a specific. Okay. Do you guys want to get set up and practice some stuff now and postpone going on lunch a little? Either way, we'll take an hour and a half. But do you want to practice now, or do you want to take lunch and then come back and we can get set up to practice in here a little bit?
Second one.
Get ready to go. That way when we come back, it's good.
Second.
So you want to set up but still go to lunch like pretty soon?
It's just an option. So we don't have to take the time to do it.
Okay, so yeah, let's maybe just get the room set up so that there's room to have a few tables and wheelchairs.